You are live.
Hello and welcome everyone. Good morning or good afternoon or good evening wherever you are. My name is Maurizio Cecconi. I am the president of the European Society of Intensive Care Medicine. I'm the host of this 30 Minutes with webinar today. It's a great honor, a great pleasure to welcome a friend and a very important intensivist from India, Professor Sheila Myatra. Hello, Sheila. How are you?
Hello. Hello, everyone. And at the outset, I'd like to say a big thank you to ESICM for giving me this opportunity. It is indeed a great honor to be interviewed by the president of ESICM. Thank you.
Thank you, Sheila, but the honor really is ours. Just for everyone, I don't think Sheila needs a lot of introduction, but she's a professor of intensive care at Tata Memorial Hospital in Mumbai, in India. She's also the president-elect for 2022 of the Indian Society of Critical Care Medicine. And her research, as we know, includes interests like hemodynamic monitoring, airway management, respiratory failure, and sepsis. So I can go on for a bit longer, but I think this is a summary of what you do, Sheila. So Sheila, first of all, how are you and how's the situation in India at the moment?
I'm very well, Maurizio. Thank you. Well, fortunately for us now, the situation in India is quite calm. The cases have started going down and things have started opening up. And as you may have heard in the news a few weeks ago, we completed, 1 billion doses of the vaccine was, given already. So, but after the devastating second wave, we have become very cautious. So we are anticipating a third wave. And we're preparing for the worst, but we're, we were hoping for the best. And so things are better, but I hope they remain like this. Touch wood.
Very good. Well, 1 billion doses is a very large number, but India is a large country.
Yeah.
How does it compare in terms of percentages of people vaccinated?
So, of course, that's not enough. With a population of 1.35 billion people, you need much more doses, and it's really a challenge to vaccinate so many people. By the time you finish giving the second dose to a few individuals, you have a whole lot of people still remaining to get vaccinated. So it's a real challenge vaccinating such a large population, but the government is really trying very hard to achieve these targets.
Very good. Just before I go on with other questions, we are receiving questions also from our platform, and I would like to remind everyone that you can post questions, and we have our social media team. I always like to thank Adrian Wong, our chair of the Social Media Digital Content Committee, because they do an immense work in trying to keep these webinars as interactive as possible. Sheila, you seem to jiggle a lot of things in your daily work, clinical work, research. You participate in many national and international societies. Can you tell us a little bit, how is your working day? How does it look like?
Right, absolutely right. My friends, they call me a juggler because I try to juggle around with too many things at the same time. Work has become very busy, actually more busy than pre-COVID times. And I work at the Tata Memorial Hospital, which is one of the largest cancer centers in the world. So as you know, cancer is a semi-emergency. So we have been operating and giving therapies throughout the pandemic. And whatever backlog has really, there's been like a rebound, and there's so much to catching up on, as is I'm sure, in most parts of the world. But with this huge population and the low proportion of doctors in proportion to the patients, the workload has become really huge. So just after this long COVID period that we had, now with the cases coming down, we are actually having to cope with a huge backlog of cases. So it's busy.
Very, very good. And can you tell us a bit more about the place where you work? What do you actually do at the Tata Memorial Hospital?
Right. So as I mentioned, this is Asia's largest cancer center. So I work in a mixed medical surgical intensive care unit, and I only work with cancer patients. So I do oncocritical care. So a bulk of our patients are with neutropenic sepsis, bone marrow transplant, and these kind of patients. I also do a bit of anesthesia, and that's where I get huge opportunity to do airway management, because being a cancer center, we have the highest workload of head and neck cancers. And that gives me a lot of challenging, difficult airway cases to deal with. So this is just a summary of the kind of work that I do.
So, and indeed, you did quite a bit of research and published on airway management in intensive care. Can you tell us a bit more how this did passion start for you about airway management? Then we have other questions that are coming from the chat related to this.
Thank you for asking me that question, Maurizio. Airway management is really a passion for me. It's not surprising that I'm interested in airway management because by training, primary training, I'm an anesthesiologist. So quite naturally, I got interested in airway management. Then I work in a cancer center where we have a huge volume of head and neck cancer cases. So obviously, I became quite an expert in difficult airway management. But then when I moved to do intensive care, I became very confident. I said, okay, I'm very good at airway management, so this should be easy. But it was a big surprise for me because I realized that all along I've been focusing on the anatomically difficult airway. And what ICU gives you a bigger challenge is, in addition to the anatomically difficult airway, you also have a physiologically difficult airway. Patients have hypotension, hypoxia, right ventricular failure, and many other complications. And these increase the risk of complications that occur during airway management. And this made me realize how casually anesthesiologists take airway management in the intensive care unit, thinking they're experts, and intensivists, from other specialties, take airway management very lightly. And it became like a mission for me to improve, just recognizing that the complications in airway management are so high. I said, I must do something about this to increase the awareness, one, about the complications and what we could do to prevent this. We actually wrote an editorial once saying tracheal intubation in ICU, life-saving or life-threatening, because we wanted people to be aware of the fact that this life-saving intervention can actually result in life-threatening complications if they are not managed properly.
And that's what you found out recently also in a large observational study, if I'm not wrong, right?
Right. So this was the Intube study, which was led by Dr. Vincenzo Risotto and Professor Bellani from Italy. I was very fortunate to be given the opportunity to lead this trial in India and be the second author in the JAMA paper. It was a global study, 3,000 patients, observational study, looking at the practices of tracheal intubation in the intensive care unit, the largest study ever. And the primary endpoint was looking at the complications. And what was very, surprising was that 45% incidence of complications and 42% was hemodynamic complications, which was a real surprise finding, because all along we've always thought about hypoxia and these kind of respiratory complications, occurring during airway management. But I think over time we've become good at peri-intubation oxygenation, and the respiratory complications have actually gone down. But what is really high are the hemodynamic complications. And this is an area where we really need to focus with future research to prevent these complications.
And physiologically, there are a lot of reasons for which an intubation, of course, interfering with heart-lung interactions can lead to that. Actually, that's often some of the topics we discuss at our hemodynamic monitoring workshops. Maybe we come back to that later. Sheila, just before we move to another topic, but I have some questions about how would you train people to be safer in terms of patient safety in intensive care. One thing that comes to my mind, I worked in different countries and I still have seen that, for instance, tidal CO2 is something that in the operating room you would not even dream to start an operation without. But still in the intensive care is not something that is performed regularly at every intubation. And if I'm not wrong, that was also something that you found out also in the Intube study, right?
Right. I'm very happy you asked me this question, Maurizio. The Intube study actually showed that only 25% of ICUs are using capnography to confirm tracheal intubation. Now, this is not just in the developing world, but also in the developed world, which is a very surprise finding 10 years after the National Audit Project highlighted in the subgroup of the complications that occurred in the ICU about increased morbidity and mortality associated with not using capnography. Even 10 years later, we haven't improved much. And this is definitely an area where we can improve awareness and make the availability of capnography and make it a mandatory check after tracheal intubation to confirm that the tube is in the right position.
So I think it's time to move to another topic that I see here. heart-lung interaction, but this time not the effect of intubation, but the effect of ventilators and prediction of fluid responsiveness. You are very proud of having developed one of the tests, which I think is the tidal volume challenge. Can you tell us a bit more the idea behind it and if you actually use it in your practice?
Right. Thank you so much for asking me this question. The tidal volume challenge is a relatively new test that we've developed in our unit, and this is used to assess fluid responsiveness. And, one of the biggest challenges in assessing fluid responsiveness when you use the tests which are based on heart-lung interactions, which is most of them, whether you use echocardiography, IVC variability, pulse pressure variation, stroke volume variation, the biggest challenge is the use of low tidal volume. So today we're not ventilating patients with, high tidal volume. Almost all patients in ICU are ventilated with 6 ml per kg. So these tests, which are very reliable in patients with ventilated 8 ml per kg, are not reliable in patients ventilated at low tidal volume. So you have very good tests like pulse pressure variation, stroke volume variation, but they're not reliable at 6 ml per kg. So we thought in our unit that, okay, you have very good tests, but they're not reliable at 6 ml. They're very reliable at 8 ml. So why don't we transiently increase the tidal volume from 6 ml per kg to 8 ml per kg for 1 minute, and then look at the pulse pressure variation or stroke volume variation? This may be able to unmask the fluid responsive patients, and then of course bring the tidal volume back to 6 ml per kg. And when we studied this in our unit, we found that the tidal volume challenge is very simple test that just involves tweaking the ventilator button, no change in position of the patient, and not even the requirement of a cardiac output monitor when you use pulse pressure variation could quite reliably predict fluid responsiveness. And subsequently, and in your unit, you've done 2 studies to validate this, not only in the intensive care unit, but also in the operating room, in patients in supine position, prone position. Now it's used for laparoscopic surgeries. And more recently, there's a study that's looked at it during spontaneous breathing attempts. So it's been widely validated internationally, and I'm very proud that this test originated from our unit. And we're doing more and more studies now using this test to expand the applicability of this test in other, to improve the reliability of other tests that use heart-lung interactions.
Thank you, Sheila. And indeed, we are also doing research in this, but I admit that I find always these studies very fascinating from a physiological point of view, and in a very controlled environment, and by taking the waves and doing the measurements, they perform well. But I admit that in real life practice, it's not always easy to see these little changes if you are at 3 o'clock at night alone in the ICU. Do you have the same issues, or have you found out a way to standardize the way you look at this test?
Yes, I agree with you. So what we look at is a change in pulse pressure variation by more than 3.5 would predict fluid responsiveness after giving the tidal volume challenge. But of course, there are limitations. So I would say a combination of all these tests, along with your clinical assessment, is paramount during managing these patients. And no test is perfect. So you have to use a good balance along with clinical assessment.
Very good. On top of this type of research, I know that you have been leading in India some large randomized control trials, especially during this pandemic. If I'm not mistaken, the COVID Steroid 2 trial. Can you tell us a little bit, because I know that India has been particularly affected by the pandemic, and I know myself that it's not so easy to do clinical work and research, and especially if you don't have a research infrastructure in place. What are the challenges that you faced? How did you overcome those?
Thank you so much for this question. The COVID Steroid 2 trial that was just published a few days back in JAMA, as you know, it was a trial led by Professor Perner from Denmark, and it was a trial between the Scandinavian countries and India. So initially, when we were approached, it was a real challenge, because I was thinking, here we are in the midst of COVID, we're barely able to handle the situation. Will we be able to do a randomized controlled trial? And we were looking at like 1,000 patients. So it was a real challenge to recruit 13 sites to do this study, and almost 40% of the patients come from India in this trial. And not only that, just even the infrastructure for research, people had limited staffing during the pandemic, getting everything set up. So it was really a challenge to do this in the midst of a pandemic. And what it really proved is that this is the time for global collaboration. We need data. Imagine comparing Scandinavia with India, a country with very high infection rates and low infection rates. So, these are real world studies, and together collaborating, we were able to achieve something really big. And it taught us that this is doable, even in India, to participate in randomized controlled trials, large global trials. So it was a kind of test for us, but I'm very proud that we were able to achieve this and in the midst of a pandemic. And as you know, this was the trial after the recovery study, which used 6 milligram of dexamethasone. This was a study comparing 6 milligram and 12 milligram of dexamethasone in patients with hypoxemia and COVID-19. And the trial, of course, showed no difference. And this was also very important in India because we were using very high doses. Mucormycosis was a concern during the pandemic. And, we were concerned about the doses that we were using. So this was the next answer, question that because steroids had not been compared head on, and whether 6 milligram was enough or we needed a higher dose. So I think this is a very, very important study. And clinically, of course, it showed that a dose of 12 milligram may be more superior. But statistically, there was no difference between 6 milligram dexamethasone and 12 milligram dexamethasone.
Very good, and congratulations on that. How do you transfer this knowledge at the bedside or in the community? We've seen everywhere in the world, actually, some issues with prescribing drugs that sometimes were not evidence-based. Maybe at the beginning you could argue that it was a difficult choice to make, but now that we have these research platforms that are providing research at very fast speed, I admit I really don't like to see all these spread use of drugs without any evidence behind it. I suspect they can even harm. How is the situation in India in that respect? And,
so I think it wasn't really very different in India. People were trying to do their best, right, everywhere in the world. And before, the evidence was still evolving, and we were trying to help patients. So of course, we made many mistakes. We used many drugs that we should not have probably used, but everything was done in the best interest, trying to save lives. So it's very good that evidence like this evolved very quickly. So, we could have the answers like the recovery trial, COVID Steroid 2 trial, and, many other trials. So our practices evolved over time, and we could have more robust data and use the drugs and therapies to save more lives.
I agree with you. And I'm sorry to go back to something, but there is a lot of interest about your expertise on airway management. And so we have a very specific question. For instance, cricot pressure in rapid sequence induction for emergency cases. Is it worth doing? Is it futile doing? What's your practice? What's the evidence behind this?
Right. So cricot pressure has been controversial. And a large reason for this is because people don't give it correctly. So it's really not going to serve a purpose. And we've also had a big randomized controlled trial that has been published showing no difference between a sham procedure and, giving cricot pressure or not. So I do use it sometimes. I mean, you have to be sure you're giving it correctly. And again, it depends on the kind of patient and, is he fasted or not? No harm in giving it, but there isn't any robust evidence to say that you should use it during a rapid sequence intubation anymore.
Okay, and in case of a surgical airway management, is it cricotectomy or a surgical tracheostomy? What should we do?
Right. So that's a very important question. So emergency, rescue, neck rescue, tracheostomy, it's always a cricothyrotomy. So you have options like a surgical cricothyrotomy or a needle cricothyrotomy. Especially those who come from the anesthesiology background are very familiar with sticking needles and doing Seldinger techniques. But you must remember, if you have a needle cricothyrotomy, you need jet ventilation. And this is not available in the intensive care unit. So there's no question that in the intensive care unit, emergency airway management, if you cannot access the airway from above, you have complete ventilation failure, you cannot ventilate using a mask or rescue the airway with a supraglottic airway device or intubate the patient, you must proceed very rapidly to neck rescue and perform a surgical cricothyrotomy. And the scalpel bougie technique is a very simple technique which can be used universally because all you need is a scalpel, bougie, and a small size tube.
Very good. You make it look like it's very easy, but I suspect not many of us had to do it, luckily, if you manage the airways properly. before, and also probably to remember young intensivists or young trainee that the most important thing is to secure the ventilation, not to secure the air.
I just like to add that the best cricothyrotomy is the one that you don't do.
Exactly.
So the most important thing is to prevent the situation, right? And try not to go down that path as far as possible. So I would say try to avoid a cricothyrotomy. But of course, you should learn how to do one just in case.
I agree with it. That leads me to the next questions. We've seen it in Europe, I've seen it in Italy, but also in the UK where I used to work before. We were lacking ICU beds before the pandemic. We were looking at how to increase the training numbers. The pandemic didn't make things easier, even if finally everyone has realized that we need to invest in developing more ICU beds. What has been the strategy in India to increase for the surge of ICU beds? And maybe later we can come back on what are your plans for training and so on.
Thank you for this question. You know, right when the cases started rising in Italy, even in China and then Italy, we were really worried because we were thinking, how will a country like India, with such a big population, so much overcrowding, and such limited infrastructure in terms of ICU beds, manage? So the first thing that we did is a very strict lockdown. I think we had the biggest lockdown in the history of the planet. It was a very, very strict lockdown, and that gave us 2 months time. So COVID cases really rose in the middle of May. And during this time, what we did is we started building facilities outside the hospital. Like we converted big stadiums, big setups into facilities so we could decongest the hospital, because we realized we would never be able to manage if a huge number came into the hospital. But really, and I'm sure you agree, Maurizio, once you have this huge number of cases coming into the hospital, your system has already failed, because this has to be contained in the community. It's about public health. No healthcare system in the world, and we've seen the best of systems collapse during COVID, can handle a surge. No matter how many beds you increase or ICUs you increase, this has to be controlled in the community, and that's where public health comes into.
It's probably tunnel vision when you just think about increasing beds in the hospital, because often that leads to stopping other clinical activities to make space to COVID. So indeed, when there are outbreaks, we've seen more COVIDs coming to the hospital, but unfortunately, a lot of important care being delayed or put on hold. So I agree with you on that. How's training in intensive care in India going now during the pandemic? Are people more attracted to the job, or actually are you finding it difficult to fill training numbers? I have to say, in Europe, we are seeing a bit of both. So the specialty being under the spotlight and finally got a little bit of recognition also from the media. But at the same time, the younger generation are a bit worried about burnout and work-life balance. How's it going where you live?
Absolutely. Well, mixed reactions, because many of our COVID warriors, especially in the intensive care, we were absolutely frontline. Many turned positive in the beginning of the pandemic. And that was, quite a scary experience. We were short-staffed, so people were overworked. There was a lot of burnout. There was a lot of fear. But over time, we were looked at as heroes. It made the ICU people be the absolute, frontline. We were the intensivists, the one who were actually managing their sick patients. So it also gave a lot of glory. So there was a kind of mixed response. But what really happened, and I call it the silver lining on the cloud, the healthcare authorities, the government, the people who really, make all the decisions, they realized what an intensivist is and what intensive care is and the importance of this. So it really brought us in the forefront. We never got this importance before COVID occurred. So it was not a nice way to get it, but I think there was a realization even among public that, who an intensivist is and what an intensivist does. And it really brought us in the limelight. So I think that was one of the positives.
And Sheila, in intensive care in India, the Indian Society of Critical Care Medicine, if I'm not mistaken, you are the first female president-elect. Congratulations on this big achievement. And what does it mean for you?
Right. Thank you so much, Maurizio. Of course, it's a great feeling to be, the president-elect of such a big society. But I can say that I did not get elected because I was a woman. I got elected, of course, because of merit. But definitely, it shows that there shouldn't be any kind of it shouldn't be, being a woman shouldn't be a deterrent to aspire for these conditions, for these positions. And having said that, I must say that for women, they have to really work much harder because there are a lot of competing responsibilities that they have. But definitely being a female in a society and the future president, it inspires a lot of women across the globe to take up leadership positions, which is much required. So I hope this will be inspiring for the future.
And thank you, Sheila, and really congratulations again on this important task. I'm sure you will lead the society very well. Talking about collaboration, you made also a lot of collaborations, scientific and clinical collaborations with other parts of the world. We've seen you linking India and Asia in general more to Europe. What do you think should be the next phase of this collaboration or this network, and what can we do with the European Society of Intensive Care Medicine for India, for instance, or with India?
This is a fantastic question you asked me. Over the last 5 years, I have personally grown a lot because I've realized that we are all doing very good work, but we are working in silos. And it is really the time for collaboration. And COVID has also exposed this. It's not that it's the developed world, it's just teaching the developing world. There are lessons to learn from everybody. And together we can do so much together for education, for research. And I think though we function individually as societies locally, this is really the time for collaboration, better collaboration. And I'm sure that will be our strength and the way forward in future.
Yes, and I'm very excited that we will have an event in India, indeed, very soon together with the Indian Society of Critical Care Medicine in 2022. It's very important for us. And as you said, I like what you said about these collaborations globally. The pandemic has really taught us that we can all learn from each other. It was certainly the first time in my life where I was faced with a limited resource setting scenario. And I learned so much from colleagues around the world that were in that situation before, and they were telling me and teaching me and sharing how you can do with it. So I agree with you. It's a network about learning from each other, about raising the standards everywhere. It's not about one teaching the other. And Sheila, we are coming nearly to the end of this 30 minutes talk. I just would like to ask you, maybe, what would you like to say to a young intensivist or to a young doctor or to a medical student that is about to choose intensive care medicine and how to develop a career? They can clearly look at you and be ambitious about having a career like yours. What would you recommend that they do? What should be the focus? What would you say to a young intensivist in India and maybe around the world?
So I think this is very important because they are our future. They are the future of intensive care. And I think it is our responsibility to mentor them and get them interested in this specialty if we want to save more lives. And I would like to say to young people that don't just do intensive care because it's glamorous or because there's money or whatever it is. Do it because you like it. Because if you don't like it, you can't make this your career. You have to like what you do. And if you don't, then you shouldn't be in this specialty. And intensive care is one specialty where there's a lot of action. There's so much happening. There's so much variation. You're challenged every day. There's so much to learn. So I think, doing what you do with passion can really keep the interest going. And I'd like to say that especially for people from parts of the world like where I come from, if you're really interested in research, you should find a good mentor. You need to, identify the area of interest, go and work in a center where, there is more cases of what you like to do and your research. So you should find a good mentor, not just go along, doing what you're doing. And this way you can really move forward. And my last message would be, no matter how brilliant you are, there is no substitute for hard work. So if you want to be successful, you have to really work hard. And most importantly, what COVID has taught me is you have to take care of yourself. Critical care is a very high intensity specialty. There's a lot of burnout. So you have to develop some interest or have something else to do so that you don't get burnt out just doing intensive care every day. So that is what I'd like to say to young people.
I agree with you. It's about taking care of oneself, but also the others of the team. And as we often like to repeat with our society is that we are intensive care because intensive care is about the team. Sheila, it's been a fantastic to spend some time with you. Thank you so much for sharing what you do, your knowledge, and how you developed your interest in your research and your clinical work. It's been a great pleasure. So thank you, Sheila, and thank you everyone for watching.
Thank you, everyone. Thank you, Maurizio, and thank you so much, ESICM.